Now we go to the second presentation to Professor Emad Zayed. Will speak about the floating shoulder. Professor Emad, Professor of Orthopedic Surgery at Al-Azhar University, will speak about floating shoulder. Professor Emad.
Good evening, sir.
Evening, sir. تمام، اتفضل دكتور عماد. فول سكرين دكتور عماد بعد اذن حضرتك. اتفضل يا فندم.
Good evening.
Evening, sir.
Our lecture today would be about floating shoulder. The content of our lectures will be definition, pathoanatomy, biomechanics, patterns of pathology and diagnosis, whether history examination or radiographic evaluation, and finally management in the form of whether non-surgical management or surgical treatment. In 1993, Goss defined the floating shoulder as a scapular neck fracture associated with clavicular fracture. And this is definitely different from any floating joint else. In the knee, the floating knee is fracture supracondylar femur and proximal tibia. In the elbow, the floating elbow is fracture supracondylar humerus and proximal both bone forearm. But definitely different here in the shoulder. In 1993, they define floating shoulder as fracture of the scapular neck associated with clavicular fracture. So here we have no fractures in the proximal humerus. With the development of 3SC or superior shoulder suspensory complex, this is an osteoligamentous ring, consists of osseous and soft tissue structures between two struts. The middle third of the clavicle acts as a superior strut, while the lateral scapular body and spine serves an inferior strut. So the component of superior shoulder suspensory complex ring include the acromion, coracoid, distal clavicle, glenoid, coracoclavicular ligament, and acromioclavicular ligament. This complex is responsible for maintaining the stable relationship between the axial skeleton and the upper extremity. The original description of superior shoulder suspensory complex didn't include the coracoacromial ligament. However, it is important stabilizer of the scapular neck fractures. Thus, the coracoacromial ligament should be considered as a part of the superior suspensory shoulder complex. So we have three components of this complex. The first component is the clavicular, AC joint, and the acromial strut, including the AC joint and the capsule. The second component is clavicular, coracoacromial, coracoid linkage. And the third component is the three-process scapular body junction. With evolution of understanding the glenohumeral anatomy leads to agreement that even though fractures are an important component of the defining of a floating shoulder, ligament disruption also must be taken into consideration. So the floating shoulder not only a fractures, but it includes a ligament disruption. So in the first slide, in 1993, Goss defined the floating shoulder as ipsilateral fracture of the scapular neck associated with ipsilateral fracture of the clavicle, but goes in 2006, it changed the option, the definition to disruption of the superior shoulder suspensory complex. So by definition, the floating shoulder is double disruption of superior shoulder suspensory complex. The combination of the scapular neck fracture with one of these associated injuries defines the floating shoulder. So the pattern of floating shoulder may include purely osseous injuries. Here we have scapular neck fracture together with coracoid fracture from the base. Here we have scapular neck fractures associated with clavicular fractures and scapular spine fractures. Another pattern is purely ligamentous, such as this pattern with scapular neck fractures and coracoacromial and coracoclavicular ligament disruption. So here we have only one fracture, which is scapular neck, and the other pathology all was ligament disruption. The third pattern combined osseo-ligamentous disruption, as in this photo we have scapular neck fractures and clavicular fractures associated with AC ligament disruption and coracoacromial ligament disruption. And here we have scapular neck fractures with scapular spine fractures associated with AC ligament disruption and coracoclavicular ligament disruption. To diagnose this pathology, a high index of suspicion for complex injury pattern is necessary when assessing a patient with injuries of the shoulder girdle. Fracture of the scapula is a severe injury frequently associated with trauma to the chest, lung, and head. The proximity of the brachial plexus as well as axillary artery and vein to the clavicle and the scapular neck make them susceptible to injury in a floating shoulder. Although ligament disruption is a key component of the floating shoulder, it is difficult to assess on physical examination as well as radiographically. So, as a floating shoulder is a major injury, for diagnosis of this major injury, associated injuries should be excluded as rib fractures, pneumothorax. So anteroposterior chest radiograph must be the first radiograph to be taken. And the other shoulder trauma series include anteroposterior view, lateral scapular Y view, and axillary view is required for further establish the type of injury. CT is an important modality to diagnose and hidden fractures in floating shoulders, such as coracoid fractures, and to assess the pattern of fracture of the scapular neck fractures and the degree of displacement of these fractures. And important factors to assess on radiographs include the amount of clavicular displacement. This is very important to decide the pattern of injury, the type of injury, and the management. Also, on the other hand, on the glenoid, we have to assess whether this fracture is intra-articular or not, the extent of comminution, and what's called lateral border offset or medialization and angulation. طبعا we know the intra-articular involvement and the degree of involvement, and whether there is a step off or not, and the extent of comminution, also all this known. But the lateral border offset or medialization, lateral border offset and the medial displacement are used interchangeably. The combination of medialization is for proximal fragment or the glenoid. The glenoid here is medialized, and the distal fragment is lateralized. And you have to assess the degree of lateralization of the distal fragment and the degree of medialization of the proximal fragment. As shown in this picture, we have here, this is the lateral border of the scapula, and this is the lateral border of the proximal fragment. And here, this is the lateral border of the distal fragment, and here, this is the space between them, or offset. The other important issue to detect in radiograph is angulation. Two methods are currently used for measuring the angular displacement of the scapular neck fractures on plane radiograph. The first angle is glenopolar angle. This angle is two lines lying from the most cranial part of the glenoid with the most caudal part of the glenoid cavity, and this line A, and the angle between this line and the other line from the most cranial part of the glenoid and the most caudal part of the scapular spine. This glenopolar angle is of value for obliquity of the glenoid articular surface in relation to the scapular body. The normal glenopolar angle range from 30 to 45 degrees. And when this angle decreased to less than 20 degrees, this is an indicative of severe glenoid rotational malalignment. The second method to assess the rotational alignment, malalignment of the glenoid is to measure the inclination angle of the glenoid on anteroposterior view of the injured shoulder. And this angle, this is the perpendicular angle over the most cranial and the most caudal part of the glenoid, and this is the perpendicular, and the second line perpendicular over the tangent of the medial border of the scapula, and this is the angle. If this angle is more than 20 degrees, this indicates of inferior glenoid displacement. So in this picture, this fracture. Did we see? Hi guys. Hello.
Sir, we see Dr. Emad.
Yes. Okay. In this X-ray, we have fracture clavicle, and the glenopolar angle is less than 20 degrees, and there is lateral offset, increase in the lateral offset of the distal fragment or medialized proximal fragment. So in every case of shoulder AB in trauma, we have to detect any associated fracture with the scapula, such as here we have fracture clavicle, whether there is fracture coracoid, whether there is fracture acromion or scapular spine, and the degree of displacement and the degree of the lateral offset of the distal fragment or degree of medialization of the proximal fragment. Reconstruction CT is very important. As we see here, we have glenopolar angle. We can measure the glenopolar angle. We can measure the degree of angulation of the proximal fragment with the distal fragment. Here we have an angle more than 45 degrees, and here we measure the degree of lateral offset, increased lateral offset or medialization of the proximal fragment. So the CT is mandatory. Because the degree of ligament disruption is difficult to assess on radiograph, indication for surgical and non-surgical management are not well defined. Though a definitive algorithm for management of floating shoulder based on scientific evidence is not possible at this time. However, review of literature does provide insight into key elements to consider in deciding how to treat the patient with floating shoulder. However, minimally displaced fracture typically do well with non-surgical management. The current recommendation for surgical intervention in articular fracture of the scapula are largely based on quantification of the 5 common measures. So we have to measure all these parameters to decide whether to conserve or to operate. The glenobular angle is very important. The articular step off is very important. The lateral border offset and the degree of translation and the degree of angulation. Again, glenobular angle less than 20 degrees is indicative of severe glenoid rotation, and this is indication for RF or reconstruction of this defect. An articular step off approximately 4 to 5 millimeters or fragment size more than 20 millimeters is an indication of surgical intervention. An intra-articular glenoid fracture with residual glenohumeral subluxation or instability after a closed reduction should be surgically repaired. So in any case of shoulder dislocation, whenever you suspect an occult fracture, you have to do CT to decide whether there is anterior rim fracture of the glenoid or posterior rim fractures of the glenoid. The lateral border offset is very important, and more than 20 millimeters of lateralization of the distal fragment or medialization of the proximal fragment is an indication of surgical intervention. However, it is extra-articular fractures, but you have to fix to regain the normal relationship between the proximal and the distal fragment. Also, angular deformity and the translation, they are parameter of displacement in sagittal plane that affect scapular glide on the thoracic wall. So when to decide to operate or not, don't think only in shoulder, but you have to think the girdle, not shoulder joint or glenohumeral joint only, but you have to think about the shoulder girdle as a whole. And the scapulothoracic junction is apart from this shoulder girdle. The angular deformity more than 45 degrees or 100 translation with no cortical contact are other indications for surgical intervention in extra-articular fractures. To decide or to order the fixation, it is debatable and remain the discretion of the surgeon. Some surgeons prefer to just fix the clavicle, allow indirect reduction of the glenoid component, and may obviate the need for posterior procedure to fix the scapula. If significant displacement persists, they go for fracture for fixation of the scapula or the glenoid. Other surgeons prefer to start with fixation of the glenoid, then fix the clavicle. How to approach to this procedure? The clavicle is, as we know, is approached through an incision directly over the subcutaneous border. Many fixation devices are allowed to be used to fix the clavicle, whether intramedullary devices, pre-contoured plate, locking plates, anatomical plates, S-shaped plates. All these implants may be used, depends on surgeon preference, osteoporotic bone or not, degree of comminution. Whatever the modality, the clavicle can be approached by many devices. On the other hand, to approach the scapula, we have 3 approaches to the scapula. The judea approach is the universal approach and the major approach, and the straight approach is a vertical approach or minimally invasive approach. Also, the implant of choice varies from recon plates, dynamic compression plates, and pre-contoured plates. The glenoid neck is approached posteriorly if the fracture is posterior the glenoid neck, but to approach the anterior glenoid rim, you have to do deltopectoral approach. Posterior glenoid rim or scapular neck, you have to go posteriorly. The posterior deltoid is either split in line of its fibers or detached at its origin and retracted medially. This is the judea posterior approach, and this is the patient with lateral decubitus position, and this is the humerus, and this is the scapula. Here we define the scapular spine, and this is the infraspinatus here, and this is the teres, this is the deltoid, and the infraspinatus and the teres. So we go through the interval between infraspinatus and the teres minor. Be careful that the suprascapular nerve pass through this site here, and the axillary nerve and circumflex vessels pass here down to the deltoid. Here, this is the suprascapular nerve and vessels, and here, this is the axillary nerve and the circumflex vessels. The site of fixation, we have to know that there is some points to be fixed. Thick solid bone for fixation is an premium because much of the scapula is paper thin. There are, however, 4 satisfactory areas: glenoid neck and the lateral scapular border. This is a solid bone, can be fixed, and the base of the scapular spine and the coracoid process, such as this picture. So we have here scapular spine, medial border, and here the lateral border. Fixation device varies as we before, 3.5 or 2.7 reconstruction plates or low contact dynamic compression plates, locking plates or plates may be valid. This is a case of fracture scapular neck together with fracture clavicle, and the glenobular angle is 17.8, and after fixation the glenobular angle regain to 30 degrees, and with fixation of the clavicle. The floating shoulder represent an uncommon but important shoulder injury. Careful assessment of shoulder girdle is required to make a correct diagnosis and to determine the course of treatment. Although the appropriate treatment of floating shoulder remain controversial, certain principle of evaluation can be applied to all patients with this injury. Surgical intervention is not required for most patients with scapular fractures. However, not all scapular fractures are best managed with benign neglect. Thank you.
Thank you so much, Professor Emad Zayed, for this very interesting talk. Dr. Ahmed Sheikh, we are waiting for any questions for Professor Emad.
Yes, thanks, Prof. Emad, for such a nice topic and presentation. I think the main message that you should not overlook any shoulder injury. Don't look for isolated clavicle or isolated proximal humerus, as most of our colleagues may do. Just need to look carefully because scapular fractures sometimes are hidden. You can't, you will not look for it if you don't know about it. So really, thanks so much about this highlight.
Thank you. Thank you.
I think one question from myself. You have said already. I think there is some controversy about the timing for fixation if you got multiple fractures, like proximal humerus fractures and clavicular fractures. In this situation, which one would you prefer to start with?
Scapular fracture, I think it is like pelvic fractures. The ideal time is from 7 days to 10 days. It is a preferred time after exclusion of any associated injury, especially the chest trauma.
Yeah.
So when the patient is purely quiet chest, we can proceed for fixation. I see some cases with severe hematoma in the shoulder girdle following scapular fractures. And I think the early intervention is somewhat, maybe critical or not
You would prefer
preferable.
to give him some time till the ecchymosis settle a bit,
Yes.
like
Okay.
tibial plateau or pelvic fracture. Just give it some time to settle. Yeah. I got one question about treating scapular fractures which is neglected after 4 weeks. Would you still go for it?
4 weeks.
Yeah.
Scapular fractures, if it is intra-articular or rim fractures, I'll proceed for fixation. Otherwise, if it is extra-articular, it is difficult.
Yeah, I think so. They will be starting to heal with the big muscle mass.
Yes.
They unite on their own.
But if it is anterior rim fractures, I think even though you can osteotomize the malunion and then refix, because it is usually have associated with instability.
Yeah, exactly. Interarticular fractures will be treated
Intra-articular.
differently, of course.
Yes.
Of course.
Okay.
One question about specific plates used for fixation.
We have many types of plate.
Yeah.
Recon plate and recon plates and specific plates also may be useful, but
Look,
recon plate
plates, yeah.
3.5 is a good option with يعني مع التنيات والشغل بقى بتبقى الامور كويسه مش فاهم. ان شاء الله.
I think we're done with questions. Thank you again, Prof. Emad, for such a good night with you. Happy to see you again and again.
Thanks Ahmed.
Thank you so much, Professor Emad Zayed, for this very interesting talk in this very scientific, fruitful night. شكرا دكتور عماد بيه.
طبعا متشكر جدا ليك دكتور محمد بيه وشرفنا بوجودنا مع حضرتك يعني بصراحه
الله
وشكرا
يخلي
جدا
سيادتك يا
للمجهود.
فندم. شرف لنا وجود سعادتك معانا.
شكرا
ان شاء الله احنا بكره عندنا حضرتك